we saw these pictures the last time I just just look at it again. This is, of course, a child with acute epiglottitis or acute supraglottitis. Not as common as it was years ago. And certainly those that are infected, have the availability of emergency rooms now, and people who are very well aware of this. My only little pearl is, and no one wants to miss these things with children, because you have someone that's got a bad sore throat, they have a temperature, they're perfect age group. It's that particular time of the year where there's a lot of possible infections around, and you wonder about supraglottitis. I think the real secret is get them to swallow. If they can swallow, you give them a nice glass of Coke or something and they can swallow it, they probably don't have much edema of the epiglottis, because if they do, they won't swallow. They will not swallow. I don't care how thirsty they are, they're not going to swallow with that amount of swelling of the epiglottis. They just won't do it. I know this works because that amount of swelling, of course, has all these muscular attachments, so it has to move when you swallow, and it won't. And so that's just I think we talked about that before. And another example of acute epiglottitis, and you can see all the secretions that pool in the postcricoid area, where we would be swallowing those, but not when we have all this swelling and discomfort. This neuromuscular activity just will not initiate itself because of the pain factor is so great. They will not swallow, or they'll do it very, very reluctantly. Now, the ones that we would see when we were at the hospital frequently are people on chemotherapy that end up with this secondary fungal infection of the entire oral cavity, oropharynx, nasopharynx, laryngopharynx. This is a good example of that. But and we've seen some remarkably disturbed cases of fungal infection, because these poor people are immunocompromised and they're being blasted with all these horrible medications, but they seldom lose their airway. You'd say, well, gosh, that's inflamed. Look at the edema that you have with the epiglottis. Well, the other factor is they're adults. They can tolerate a certain amount of edema, but they don't lose their airway. They really don't. They can really look terrible and go on for a long period of time because these programs of chemotherapy can go on, and you can see that here. They're ill and they may not want to swallow just because they're so weakened and frustrated with their disease, but they don't lose their airway. You'd say, well, all inflammations of the laryngopharynx end up with a loss of airway. No, not necessarily. This inflames all this fungal debris. You can see it here as well. They're able to swallow. Now, the rule of thumb when it comes to hoarseness, I think anyone who's hoarse, even if they say it began with acute laryngitis, anyone that's hoarse for more than 3 weeks, there has to be an examination made of the larynx. Now, they may refuse. They may say, oh, I'm fine. I had laryngitis because it was laryngitis at work. How long ago was that? Oh, that was a month ago, and your voice is still disturbed. Yes, but it's going to go away. I don't buy that. Most people with a truly acute viral laryngitis, the vast majority are viral in nature, will begin to resolve after about 2 or 3 days, and then just rapidly progress to resolution within 12 to 14 days. So anyone who has hoarseness that lasts, everyone is their own particular duration factor, but I think anyone who is hoarse more than 3 or 4 weeks, someone better look at their larynx. This is a good example. Here's someone who has no symptoms other than hoarseness, and you see this little area right here on this patient's right vocal cord, and that would contribute to hoarseness. And this is very suspicious for very early malignancy of the cord. And that's how they usually present. They don't, and they're often not bilateral. They're usually just on one cord. So this is the squamous mucosa, and so you're getting some squamous dysplasia there. And it might be just all dysplastic, it might be all in situ, but that would obviously something that you would never even remotely treat with anything except a critical evaluation by getting a little piece of that and seeing what the pathologists say. That's how they begin. They don't begin, initially with particularly cord lesions. We're talking about lesions of the true vocal folds, or they don't begin with just an enormous growth. They usually begin with, the characteristic features that you read about, a little patch of leukoplakia that becomes further involved, and it becomes dysplastic, and finally truly anaplastic. That's how they begin, just like that. So this would definitely, particularly if there's usually a significant history of alcohol and tobacco, it has to be, I would say, let's just remove a little bit of this. As you can see, this procedure is being done. There's the endotracheal tube. We're just going to take a little piece of that, see what it shows. And that's the way to handle these people who are persistent hoarseness. Laryngeal cancer is still something that we encounter. Another example of a laryngeal cancer, right there. Now, this area where the vocal cords come together is called the anterior commissure. Now, grossly, when you look at this, you'd say, well, the commissure isn't involved. No, it's just this cord, this anterior 1/3 of this vocal cord has this sort of hyperkeratotic, slightly exophytic lesion there that is troublesome, no doubt about it. And here's one that goes up, involves the commissure. It extends to where the cords meet, which is called the commissure. There it is. Now, what you want to kind of recall is the lymphatic supply to the true vocal fold is really scant. So people with early cancers of the true vocal cord rarely have metastatic disease in the surrounding lymph-bearing tissue of the neck. They just, they can eventually, but since the lymphatic supply is relatively meager, they don't generally present, if the history of hoarseness is maybe a month or two duration, with a metastatic neck mass from true cord lesions themselves. Now here's a perfect example of a vocal cord cancer right there. Now, how to handle vocal cord cancers? Well, they depend on where they're located. They go through this staging of T, N, M, O, and this would be a very early cancer of a mobile cord. See, this cord probably moves quite well. It hasn't invaded the vocalis and the thyroid muscle very far. So technically, that lesion you could take very carefully with laser and remove that, and probably feel comfortable in that you've cured it. Now, they can be obviously bigger than that. Here's a nice growth. This involves the commissure, and then it comes over onto this cord. So that one would be impossible to treat, that one with laser. But once again, they can be treated. This is a lesion that probably one would treat initially with radiation, simply because you want to try to save the larynx, if at all possible, to save the larynx. So I'd say the cure rate for this is significantly high with definitive radiation. And if radiation didn't work, then you could fall back on a surgical procedure. Cancers of the cord are very seldom treated with chemo radiation as an initial treatment of the true cord. We're talking about the true cord. Let's see if we have another. Now here's a bulky tumor of this cord here. Doesn't seem to involve the commissure. Another way of handling this, which is really effective. Now this has come down into the muscle part, the muscular part of that cord. you could do what is referred to as a laryngeal fissure and remove this. You put in a temporary tracheotomy, and you can split the larynx in front here with a nice little oscillating saw. You literally open it up like a book. It's fascinating. And then you can go down and very definitively remove this entire true vocal fold, the ventricle, and part of the false chord. Send the whole thing out, send it to pathology, let them section it right there, make sure that it's completely removed, and you've cured it. Now you might say, well, what happens? Well, this area is now open, and you've got an NG tube here, here in the esophagus. You've got a trach tube, so they're going to have a perfect airway. They're going to be able to receive nutrition, and you just wait this out until this area starts to heal in, and they can essentially swallow without aspirating. And then when that happens, you can take your trach tube out and take your NG tube out, and it works. How long does it take? Surprisingly shorter than you think. Usually within 2 weeks, there's enough reparative tissue here that acts like a cord. Now it doesn't move to the middle, but this cord can come over to touch it to give you a competent larynx. That's all you need is competency. They can swallow without aspirating, and away they go. And as this heals, obviously it doesn't move like a cord, but you'll end with this remarkable band of scar tissue that is very tight and very full, and this cord comes over and touches it rather well, so they're a little bit husky, but their voice is very acceptable. And once again, you're able to do this because the lymphatic supply of the cord is not that great. Now, depending on how deep this is, you might have to change your surgical strategy, but it's something we've done many times. It's called laryngeal fissure and cordectomy, and it works for isolated lesion. Now, but at the same time, you'd offer them the option of at least trying to cure this with radiation. If radiation fails, you could go back and do surgery. The only downside of a failure where you have to consider surgery is when you radiate this, you radiate cartilage. So you're cutting through radiated cartilage. There's always a risk that you'll end up with successful surgical operation. So you've saved the larynx, they failed radiation, but then you end up with chondritis, which can really be a bear cat. But surprisingly, people with post-radiation chondritis can respond to intense antibiotic therapy and hyperbaric treatment. And surprisingly, has worked for us. You just don't want to have an infection. Now, they don't all get infected because they've been radiated, but there's a likelihood that they can be. Now, here's a real bulky lesion. Now, you might say, oh, gosh, that involves that whole cord, and it seems to be in the commissure for sure, and it spills into the ventricle. Oh, that one is not going to be really amenable to a partial surgical procedure. Then you begin to wonder about, well, can that be done with radiation? It's a tough one. My advice would be definitive radiation. If that fails, then remove the entire larynx. And people can live comfortably without a larynx. Particularly if they master esophageal speech, or they have a tube placed where they can ventilate, where they have an adequate airway, and then they can use that tube to speak. And here's a good example of a real nasty larynx. Now look at, excuse me, let's go back, because this shows you how this is someone who has two vocal, doing it again. You'll see there's two vocal cords here, and there's no tumor on these cords. There's a vocal cord fold here and fold there. and you see this enormous cancer of the epiglottis. What are these people complaining of? A constant sore throat. They've had 2 or 3 rounds of antibiotics and the throat is still sore. And then they'll present, because this has a very rich lymphatic supply. They could present with metastatic disease in both necks, in the lymph-bearing tissue associated with the internal jugular vein. They may present with a neck mass, and lo and behold, a sore throat that they've had all winter, and you see this very big cancer. Now, technically, since both vocal cords work, they're not involved with tumor, this entire area, all this supraglottic area, can be removed surgically. All of this can be removed surgically. Of course, the margins have to all be checked. Obviously, they have a temporary tracheotomy tube. And so you're essentially bringing the area above the vocal cords, which is free of tumor, and suturing it to the base of the tongue. And I say, oh, that's horrible. No, it works, because they have a competent larynx. So they can talk, and if the larynx is still competent as it heals, they don't aspirate it. Now they'll have an NG tube or a PEG tube in a tracheotomy, but these people can do rather well. But in lesions such as this, if you fail to cure these people, it's because they have metastatic disease in their neck, because of this very rich lymphatic supply of these tumors. So once again, someone has a persistent sore throat, a heavy smoker and drinker, and has a neck mass, you wouldn't think of an infection, you would think of metastatic disease from such a lesion as this, and it happens. It happens, believe me. Particularly when they say, I've had a sore throat all winter, and I don't seem to be getting any better. And then you see this enormous growth here. And these are squamous cell cancers. It's a very common cancer because this is squamous mucosa. It's curable. Now you might say, well, what would, they want to save this larynx, what would the protocol today be? Well, today the protocol would also involve some element of chemotherapy as well. Chemotherapy, radiation, and then a salvage surgical procedure would be undertaken for these particular patients. You know, earlier we mentioned this little gutter area that occurs on each side of the larynx called the piriform sinus, and then this is the postcricoid area right here. This is a good example of cancer of the piriform sinus. Once again, the cords aren't involved. These individuals they can present with a sore throat, but with a lesion this big, there's a very great likelihood that the lymph nodes on this side of the neck are going to be involved with tumor. And here again would be chemotherapy, radiation, and sometimes the larynx has to be removed. You just cannot salvage this larynx. But the emphasis today is to try to salvage the larynx if at all possible with any modality that you can use. Years ago, sometimes the laryngectomy was the only hope that we could offer these patients. But people without a larynx can communicate through esophageal activity, and obviously they have a permanent stoma in the anterior lower part of their neck, and they function rather well, except in the wintertime sometimes their stoma gets crusted and dried, so they have to worry about humidification. I think that's about all of the ones that we have. Any questions that you folks might have, I'd be glad to answer.
How do you visualize the vocal cords? Like if you're concerned about hoarseness or...
Well, you have to do it visually, either with mirrors, which is sort of an anachronistic way that I still use because I'm anachronistic. But otherwise, we'll use a flexible laryngoscope.
Okay.
You'll be able to see them with a flexible laryngoscope.
What do you have in your office? Like when you see patients, besides the like a microscope?
Well, the microscope is for the ear.
Yeah.
You mean that headlight I use?
Just in general, like what do you have in your office? I guess Dr. Dulac was asking me some questions.
Have
What kind of procedure would you be doing in there? Like ear tubes or sure.
Right, that would be about right. Ear
What,
tubes,
just
we
ear
can
tubes?
remove tubes.
Okay.
Ear tubes are easy to do. Simple polyps in the nose we can do. Probably nothing more than that surgically.
Okay.
Simple nosebleeds, we can do. There are simple things that can be done. But if it's a question of needing other instruments or some special form of cautery, that's not to do anything except in operating room setting. It just isn't advisable.
Thank you, Dr. Demarco.
Super.